Hi everyone, this is the pre-class PowerPoint for the second part of circulatory function. And what I'd like to do is to go back and look a little bit more at the anatomy of the heart and some of the things that can go wrong with its different parts. Let's look first at the heart valves. You remember we said the other day that the function of the heart valve is to make sure that the blood goes in the right direction through the heart chambers, to make sure that blood is not going backwards. And of course we have the two main kinds of heart valves. We have your atrioventricular valves, or we call them AV valves, that monitor the flow of blood between the atria and the ventricles. And then we have the semilunar valves, which monitor the flow of blood out of the ventricles. Now, what I want you to notice at this point is that there are no valves at the entrance to the atria. So there really isn't anything to keep the blood from backing back out of the atria once it's gone in. Now, usually that's not a problem, but if you had a patient with heart failure or something like that that causes the atria to become overfilled, then we might start seeing some problems with blood backing back out of the atria. We'll talk more about that later when we talk about heart failure. Sometimes the valves become stiff or deformed, maybe because of trauma, maybe because of inflammation or ischemia. And when that happens, then the heart valves may not be able to do their job. So you're going to see changes in the flow of blood through the heart. Now, usually when the valves are damaged, you're going to see one of two scenarios. You're either going to see valves that cannot open properly or valves that cannot close properly. Now, if you see valves that can't open properly, we call that stenotic valves or narrow valves. And if you have a valve that can't open properly, then you get a really, really tiny opening like you see in picture A. Okay? So now we're going to have trouble pumping enough blood through that valve because it's so small. In that situation, what do you think is going to happen to the workload of the heart? It's going to go up, right? The heart's going to have to work extra hard trying to move all of that blood through that little tiny opening. Now, what do you think is going to happen to cardiac output? It's probably going to drop, right? Because if we can't get the blood through the valve, then we're going to have trouble filling ventricles and that kind of thing. So when you have a stenotic valve, the workload of the heart goes up, but the cardiac output goes down. What if you have the opposite problem? What if you have a valve that can't close properly? When that happens, we say we have an incompetent valve or a regurgitant valve. And that's what you see in picture B there, a valve that can't close properly. So if the valve can't close properly, what problem are you going to have? Probably you're going to see blood going backwards through the valve, because even when the valve is closed, there's still an opening so that blood can flow backwards through that opening. Now, again, what's going to happen to the workload of the heart? It's going to go up, right? Because now this poor little heart is going to have to pump some of that blood more than once through that valve, because it'll pump it from the atria to the ventricle, and then the blood's going to leak back into the atria, and so now the heart has to pump it through again. So the workload of the heart goes up, but what happens to cardiac output? Is going to drop, right? Because if blood is going backwards, then the amount that's going forwards out of the heart is going to drop. So again, we see a scenario where the workload of the heart goes up, but the cardiac output drops. Now, sometimes people have valve problems like this, but they're not very severe. There may be only a mild stenosis or a mild regurgitation. And if that happens, you may not see somebody showing signs of poor cardiac output. But even if that's the case and you don't see signs of poor cardiac output, when you do a physical assessment, you will still know that that valve problem is there. How do you think you'll know? When you listen to the heart, what are you going to hear? you're probably going to hear a heart murmur, because heart murmurs are the sound that you hear when you have turbulent blood flow. Okay, if you have blood that's trying to force itself through a really tiny opening, or if you have blood that's flowing backward through a valve, that's going to generate a bunch of abnormal vibrations that you're going to hear as a heart murmur. Let's talk next about the pericardium, which we said last time was like a little fibrous sac that surrounds the heart, that helps hold the heart in place in the chest cavity, and that provides some protection for the heart. The pericardium actually consists of two layers. The outside layer, you see the little red arrow pointing towards the outside layer, is a really tough layer. We call it the fibrous pericardium. And it's a very tough layer made out of tissue that doesn't stretch. The second layer of the pericardium is actually a double-layered membrane. A double-layered membrane, you can see the red arrow pointing towards there, and there's a little cavity or a little space in between the two layers of that membrane. In this picture, you can get a slightly different concept on this double-layered membrane in the pericardium. The fist there represents the heart, and you see the double-layered membrane that surrounds the heart with this space in between the two layers. And in that space, there is some serous fluid. Not a lot, maybe 30 to 50 milliliters, which is like 2 or 3 tablespoons of fluid. So it's not a lot, but it's enough to provide some lubrication so that there's no friction when those two layers rub against each other. You have to have one of these double-layered membranes with a small amount of serous fluid in between the layers whenever you have an internal organ that moves. Now, does the heart move? Of course, it contracts and it relaxes. And as it contracts and it relaxes, the two layers of that membrane rub against each other. And we have that fluid in there to lubricate it so that we don't get all the friction damaging the two layers as they rub against each other. So you can see that the pericardium actually provides physical protection for the heart and the sac around the heart, so that as the heart moves and the layers rub against each other, they don't damage each other. It also provides some physical protection from some other stressors. It provides a barrier to infection, so that if you get an open chest wound and pathogens enter your chest cavity, it would have to go through all the layers of the pericardium before it could enter the heart and cause an infection there. Also, the outside layer, the fibrous pericardium that we said was made out of tough, non-stretchy material, that protects the heart from getting overfilled. You know, you don't want the heart to get so much blood in it that's going to damage the heart wall or even cause it to rupture. So we have this fibrous pericardium on the outside of the heart to prevent the heart from overfilling. Here you can see an example of a problem that can affect the pericardium. We call it pericardial effusion, and it's what happens when way too much fluid gets in the pericardial space. Now, we said that normally there's only a small amount of fluid in there to decrease friction. But sometimes if there's inflammation or infection or trauma, you can get an abnormally large amount of fluid in that space. Maybe the fluid is serous fluid, maybe it's pus, maybe it's blood. But you can see how if too much fluid collects in that space, it's going to start compressing the chambers of the heart. Now, if we get way too much fluid in there and it's starting to interfere with the ventricle's ability to fill, then what is that going to do to cardiac output? It's going to drop our cardiac output. If that happens, we call it cardiac tamponade. So if the pericardial effusion gets so bad that it is interfering with the filling of the ventricles, it's compressing the heart chambers, it's impairing cardiac output, then we call it cardiac tamponade. And you'll probably learn about how to treat cardiac tamponade when you get into critical care, because it is a very critical type of illness. What about the other layers of the heart wall? Okay, the next layer in from the pericardium is the myocardium. You can see the red arrow there pointing at it. It's a thicker layer. It's the muscle layer of the heart wall. This is the layer that performs the actual work of the heart, which is, of course, contracting and relaxing. Okay, so, if you look at the word myocardium, when you use the root myo, what does that mean? Refers to muscle. Okay, so this is the muscle layer of the heart wall. Some examples of some problems that can affect the myocardium. How about cardiomyopathies? Okay, you break that word down and it tells you exactly what it is. Cardio refers to the heart, myo refers to muscle, apathy is some kind of pathology. So cardiomyopathy is a disorder that impairs the function of the heart muscle. Now, cardiomyopathies are not one single disease. It's a whole group of disorders that all affect the heart muscle. Some of the cardiomyopathies are genetic, some are viral, some are autoimmune. The thing that they all have in common, though, is that they impair the pumping ability of the heart. And so if we impair the pumping ability of the heart, what do you suppose happens to cardiac output? It drops, okay? And so you might see signs of heart failure. Another example of a problem that affects the myocardium is a heart attack, right? Remember what the technical term for heart attack is? It's a myocardial infarction. So it says right there in the name that it's a problem of that heart muscle layer of the heart wall. Of course, if you have a heart attack, what does that do to the pumping ability of the heart? If you've got a part of the heart wall that has died and is no longer contracting with the rest of it, what do you suppose happens to cardiac output? It drops. Okay, so are you starting to pick up a common theme with all of these heart disorders? Almost all of them are going to impair cardiac output. All right, let's look at the very inside layer of the heart wall. We call it the endocardium. You see the little red arrow pointing at it. It's much thinner than the myocardium. It's actually a very thin membrane that serves as the inner lining of the heart. So it's nice and smooth, it's slippery, so clots don't form on it, platelets don't stick to it. Hopefully even microorganisms can't stick to it. And so it provides some protection also from infection and clot formation and that kind of thing.
The most common problem that affects the endocardium is called infective endocarditis. And if you break that term down, you'll see what it's all about. Itis means inflammation of, so obviously we have inflammation of the endocardium caused by infection. Right? What happens in infective endocarditis is the surface of the endocardium gets infected with pathogens, and that leads to the development of what we call vegetative lesions that can then destroy the underlying tissue. It's most common in people with some kind of pre-existing heart defect, like defective heart valves or maybe prosthetic heart valves, because you remember we said that the endocardium is usually smooth and slippery and pathogens can't stick to it. But if you have some kind of defect, that provides little nooks or crannies where pathogens can grab onto and hang on, and then they can multiply and cause inflammation from there. You also see it in people with implanted pacemakers, implanted defibrillators, maybe central lines, those kinds of things that, provide access to the heart and also provide things for the pathogens to hang on to. Now you remember that we said the pericardium was supposed to protect the heart from infection, right? We said it provided a barrier so that if pathogens got into your chest cavity, they would have to go through the pericardium to gain access to the inside of the heart. So how do you suppose the pathogens that cause infective endocarditis actually get in the heart? Through the blood, right? Because all the blood in the body eventually pumps through to the heart, so all an organism would have to do would be to gain access to the blood, and then it could be carried to the heart. So the original portal of entry for this pathogen could be pretty much anything. It could be an upper respiratory infection. It could be an infected skin wound. It could be, somebody had a dental procedure and their gums got nicked and organisms entered through that cut. Any way that an organism can get into the body, from there, if it can get into the blood, then it could theoretically cause infective endocarditis. So people with heart defects, like valve problems and that kind of thing, they need to be extra careful. And anytime they're going to have any kind of invasive procedure, they need to make sure that the healthcare professional who's going to do that procedure is aware they have these defects and might be at risk for infective endocarditis. Have you ever gone to the dentist as a brand new patient and had to fill out a health history asking about things like, do you have a heart murmur? And have you ever wondered why he even cares whether you have a heart murmur? Well, it's because if you do have a heart murmur, that means you are at risk for infective endocarditis, and he would want to evaluate you to see if he needs to give you prophylactic antibiotics before he does any kind of invasive procedure on you. And by prophylactic, I mean preventive. Okay, he'd give you antibiotics to make sure you don't get infective endocarditis. Anytime you have any kind of invasive procedure, if you have a risk factor for infective endocarditis, you need to make sure you let the healthcare professional who's going to do that procedure know. And, most healthcare professionals are aware of this risk, and so they make sure they try and identify anybody who might need to be on prophylactic antibiotics. And what they would usually do is send you to be evaluated. I actually have a mild heart murmur that is so mild it doesn't cause any problems with my cardiac output. But when I was pregnant, my OBGYN sent me to get an ultrasound to make sure, how big a risk would I be at, and does she need to give me prophylactic antibiotics when I went into labor? And as it turned out, she decided it wasn't called for. So it won't be done in every case, but, we at least evaluate people who have the heart murmurs. Now, you remember we said that infective endocarditis leads to the development of what we call vegetative lesions, usually on the valves of the heart. When I was a nursing student and I learned about vegetative lesions, in my head, I was thinking like, oh, vegetation, it must be like little plants that are growing on the heart valves. So I was picturing them like little mushrooms. That's not what they are at all. Those vegetative lesions are actually made up of three things. There's microorganisms and cellular debris, all tangled up in strands of fibrin. Okay, microorganisms and cellular debris, all tangled up in strands of fibrin. Now, when you have these kinds of lesions on your heart valves, there are three problems that we worry about. The first problem we worry about is, you remember we said that these vegetative lesions have pathogens in them, right? And so as the blood pumps through the heart chambers, as it passes the vegetative lesions, it could pick up some of these pathogens and then carry them to other places in the body where they might start problems in those other places. The second thing we worry about is, you remember that we said these vegetative lesions usually destroy or at least damage the underlying tissue. So now we're looking at probably some more severe heart valve damage than already was present to start with. The last thing we worry about is that maybe a piece will break off one of these vegetative lesions and become an embolus. It can travel in the blood to some smaller artery where it's going to totally occlude it, and now we're going to have problems with bad circulation, possibly infarction of different body tissues, depending on which artery gets clogged by that piece of the vegetative lesion. To give you an example of what might happen, my husband had a classmate in high school whose older brother apparently had a heart valve problem that he didn't know about. And one day he ate in some little hole-in-the-wall restaurant and got food poisoning, and that was the portal of entry for the organism, and he developed infective endocarditis. But by the time they figured out what was going on, he'd already had vegetative lesions, a piece had already broken off, and it got stuck in an artery in his brain and caused like a mega stroke. And he actually spent the rest of his life in an extended care facility in a vegetative state, and eventually, like 20 years later, died from pneumonia. Now, it doesn't always end that bad. Some people do survive. I did see a article on one of the news websites about a guy who said he was eating popcorn while watching TV one evening, and a piece of popcorn got stuck in his teeth. So he tried a whole bunch of things to try and get it out, right? He used whatever was handy. So he started with the cap of a pen, he moved to a toothpick, then to a wire, and then to a metal nail, and still was not able to get the piece of popcorn out. But by then he'd already injured his gums, and apparently an organism got in there, and he must have had some kind of heart defect, so he developed infective endocarditis. But they did catch it early enough to prevent any, really major consequences. And so he did survive to be interviewed for that article. But the bottom line is, we really have to be careful with people who have the risk factors for infective endocarditis. All right, let's talk about heart failure next. When we use the term heart failure, we are referring to the failure of the heart as a pump. The heart is not pumping effectively enough to meet the needs of the body because the cardiac output is too low. Okay? Heart failure does not mean that the heart has stopped beating, right? Because we have another term for that. Do you know what it is? And don't say dead. Okay? When the heart stops beating, we call that cardiac arrest. Okay? Heart failure is not cardiac arrest. The heart is still pumping. It's just not pumping effectively enough to meet the needs of all the body. Now, sometimes when we talk about heart failure, we call it CHF, congestive heart failure. Congestion just refers to the accumulation of fluid somewhere in the body. And if you think about heart failure, it does make sense, right? Because if the heart is failing to pump the blood forward the way it's supposed to, that must mean that the blood is backing up or accumulating somewhere else in the body where it's not supposed to be. Does that make sense? For this reason, you often hear people refer to the forward effects and the backward effects of heart failure. The forward effects are the problems that the patient has because the blood is not getting pumped forward where it's supposed to be. And the backward effects refer to the problems the patient has because the blood is backing up somewhere where it's not supposed to be. Okay? So, on the test, I'm not going to ask you, is this symptom a forward effect or a backward effect? Because, it really doesn't matter. The only reason I'm presenting it to you in these terms is because it's easier to remember what all the problems that heart failure can cause if you can cluster them into a couple of different groups. Instead of trying to remember 12 different things, you can just remember 2 things and, remember all the things that will fit into those categories. So we will, as we talk about heart failure, talk about the problems that patients have because the blood isn't getting pumped forward. And then we'll talk about the problems that the patient has because the blood is backing up somewhere where it's not supposed to be. And hopefully that will help you to remember all of the different kinds of problems that the patient will have. There are 2 kinds of things that can predispose to heart failure. The first is impaired cardiac function. Anything that decreases cardiac output, anything that impairs the pumping ability of the heart, can lead to heart failure. So things like cardiomyopathy, myocardial infarction, heart valve diseases, any of those things that we talked about that can decrease your cardiac output, those things can potentially cause a heart failure. Does that make sense? The second thing that can predispose to heart failure is excessive work demands. When the heart is asked to work very hard, it can get overworked, it can get overwhelmed, and then it fails. Okay? So if the patient has chronic, really high blood pressure, okay, remember when the heart has to pump blood out into the arteries against all that high pressure, it has to work harder to do that. And it might get overworked. If you are fluid overloaded, then you're going to have a lot more blood volume than you normally would. And now that the heart has to pump all of this expanded blood volume, it gets overworked, it gets overwhelmed, it might fail. So those are the kinds of things that you would expect to see in the history of a patient with heart failure. Okay, so the primary problem in heart failure is poor cardiac output, right? And we can divide things that cause poor cardiac output into 2 groups. We would have systolic heart failure and diastolic heart failure. Now we know that systole is when the heart contracts and diastole is when the heart relaxes. So systolic heart failure is when there's poor cardiac output because of problems when the heart contracts. And diastolic heart failure is problems with cardiac output because of problems when the heart relaxes. Okay, so let's look at some examples of each. Systolic heart failure. Anything that interferes with the strength or the force of contraction. anything that makes it hard for the ventricles to contract, anything that makes heart contraction weaker can cause a systolic heart failure. So we're talking things like cardiomyopathy, right? A disease of the heart muscle. You remember the heart muscle is the part of the heart wall that does the actual work of contracting. Myocardial infarction, right? If part of the heart muscle dies, of course the contraction is going to be weaker and you're going to have poor cardiac output. So those are the kinds of things that can cause systolic heart failure. What about diastolic heart failure? Now we know diastole is when the heart muscle is relaxed. And what is the ventricle supposed to be doing when the heart muscle is relaxed? It's supposed to be filling with blood, right? And if the ventricles don't fill adequately with blood, then what happens to cardiac output? It's going to drop, right? Because if the ventricle doesn't fill with very much blood, even if it contracts, then not very much blood is going to go out with that contraction. So anything that interferes with the ability of the ventricles to fill can cause diastolic heart failure. So we're talking things like chronic hypertension, right? Because you remember hypertension over time makes the ventricular walls hypertrophy, so it can generate enough force of contraction to pump blood out into the arteries against all of that high pressure. So when the size of the heart wall thickens, what happens to the size of the chamber? Okay, look at that picture on the right where we have labeled diastolic heart failure. You see the left ventricle walls have hypertrophied and thickened. What happened to the size of that ventricle chamber? It got smaller, right? Now that it's smaller, it can't fill with as much blood, so cardiac output is going to drop, and that can cause a diastolic heart failure. Another example of something that can cause diastolic heart failure. What if you have a patient with cardiac tamponade, right? We just got through saying that in cardiac tamponade, there's compression of the ventricles so that they can't fill. And if they can't fill, then cardiac output's going to drop. So cardiac tamponade can also cause diastolic heart failure. Does that make sense? Okay, another thing to think about is some people actually have both systolic and diastolic heart failure. So those people are in real trouble. Now explain systolic and diastolic heart failure to you using those names, because everybody knows what systole and diastole is, so I think it's easier to understand that way. But I wanted to introduce you to the newer terms that we're using instead of systolic and diastolic heart failure, and that is reduced ejection fraction failure and preserved ejection fraction failure. Okay, that's actually easy to understand as well if you know what ejection fraction is. The ejection fraction just refers to the percentage of the blood that gets ejected from the ventricle when it contracts. Okay, so interestingly enough, when the ventricles contract, it does not eject 100% of the blood that's in there. Okay, a normal ejection fraction is somewhere between 50 to 75%. So the ventricle is not totally empty of blood after it contracts. There's always a little bit of blood that's left in there, and the ejection fraction is just a measure of how much of the blood that was in the ventricle actually goes out with each beat. Okay, usually we measure it by ultrasound. But if you think about what ejection fraction is, it does make sense, right? Because in systolic heart failure, systole is when the heart contracts and is ejecting the blood. And if the heart's having trouble contracting, then there's going to be a reduced ejection fraction, right? So we'll call it reduced ejection fraction failure. Whereas in diastolic heart failure, the problem is the heart doesn't fill with blood, right? There's no problem with the heart contracting. It does that just fine. So the ejection fraction is preserved, right? Ejection fraction should still be good because the ventricle can still contract just fine. The problem is it can't fill with very much blood, right? So we call diastolic heart failure preserved ejection fraction failure because it does fine in ejecting the blood. It just doesn't fill properly. Does that make sense? So we know that heart failure is caused by poor cardiac output. And the body does have some compensatory mechanisms that are designed to help us boost our cardiac output back up when necessary. But the problem is most of these compensatory mechanisms were not designed for long-term use. They were designed for short-term use only. And if we try to use them in long-term situations, they will eventually become counterproductive and actually make the heart failure worse. Let's talk about what some of these compensatory mechanisms are, and then I think you'll see what I mean. All right, compensatory mechanism number 1. When the cardiac output drops, the sympathetic nervous system kicks in because, when the cardiac output drops, the body does interpret this as a crisis and takes steps to try and bring the cardiac output back up, right? So the sympathetic nervous system will increase the heart rate, increase the force of contractility to try and bring the cardiac output back up. And it does succeed, but when you increase the heart rate and you increase the force of contraction, what have you just done to the workload of the heart? You've increased it, right? And now that the heart has to work harder, that's eventually going to make the heart failure worse. Does that make sense? Compensatory mechanism number 2. When the cardiac output drops, the blood pressure is going to drop, right? And when the blood pressure drops, that activates the renin-angiotensin-aldosterone system, which I know we've already reviewed this quarter. Now, you remember that after you activate the renin-angiotensin-aldosterone system, you end up retaining sodium and water, and you increase your blood volume. So in the short term, when you increase your blood volume, that should bring your cardiac output up. So in the short term, that helps. But in the long run, when you increase your blood volume, what have you just done to the workload of the heart? You've increased it, right? And remember, activating the renin-angiotensin-aldosterone system will also cause vasoconstriction and increase the blood pressure. And if you have vasoconstriction and increased blood pressure, what does that do to the workload of the heart? Yeah, the heart will have to work harder now to pump blood out into the arteries against all of that pressure. So while activating the renin-angiotensin-aldosterone system works well in the short term, in the long run, it increases the workload of the heart and is going to make the heart failure worse. Compensatory mechanism number 3. When the cardiac output drops, the body releases several hormones that cause hypertrophy and thickening of the left ventricle wall, with the goal of, now that the heart muscle is thicker, hopefully can generate more force and can improve the cardiac output. Now, that does work in the short term, but in the long run, when you thicken the walls of the left ventricle, what's happened to the size of the left ventricle chamber? Yeah, it's gotten smaller, so it can't fill as well. And if, the left ventricle can't fill, that's going to decrease cardiac output. The heart failure is going to get worse, right? Not to mention that now that the left ventricle heart muscle is thicker and bigger, it needs more blood and oxygen and fuel, right? And if this person has any atherosclerosis in their coronary arteries, we may not be able to supply as much additional blood and oxygen and fuel as that hypertrophied heart muscle now needs. So we might actually be setting this person up for ischemia, which, that will lead to even worse heart contraction, right? Because if you have ischemia, you won't have the oxygen to make the ATP, so the heart muscle contraction is going to get a lot weaker. So this is not a good scenario in any respect. So can you see how the compensatory mechanisms we've already mentioned, while they might be helpful in the short term to improve cardiac output, in the long run they're going to be counterproductive because they increase the workload of the heart and will therefore make the heart failure worse. There is, however, one compensatory mechanism that can be helpful. Under heart failure conditions, the heart will release two peptides, ANP and BNP. ANP stands for atrial natriuretic peptide, and BNP stands for brain or B-type natriuretic peptide. Now, ANP is released by the atria. That makes sense, right? Because that's why we call it atrial natriuretic peptide. BNP, however, is not released by the brain. BNP is actually released by the ventricles, and that's why some people prefer to call it B-type natriuretic peptide instead of brain natriuretic peptide. So you might wonder why we call BNP brain natriuretic peptide, and I went looking for why that was, and I finally found a resource that said that we first isolated BNP from the brain of pigs. But in people, BNP is released by the ventricles. Okay, so ANP and BNP released by the atria and the ventricles under heart failure conditions to help counteract or compensate for some of the problems that are going on. So here are the effects of ANP and BNP, and you can see that they sort of help counteract some of the negative effects of the other compensatory mechanisms. They decrease sympathetic activity, they decrease sodium and water retention, and that's what natriuretic means, right? Natriuretic means that we're excreting sodium in the urine, okay? And these two peptides will also decrease vasoconstriction. So all of those things will help counteract the negative effects of the other compensatory mechanisms and can be very helpful in heart failure. Okay, a couple last things I want to mention to you about BNP, and that is we can actually measure BNP levels in the blood, and sometimes we'll do that in the emergency department when somebody comes in heart failure, and we want to know how severe that failure is. Usually, the higher the BNP level, the more severe the heart failure is. Also, we can now make BNP synthetically, and so we sometimes give it to people with severe heart failure to try and get some of these useful effects. It, at this point, is only available in an IV form, and therefore we can't send people home on it. We do need to kind of monitor people while they're on it as well, and so usually we're giving it to heart failure patients that are sick enough to be in the ICU. Now, I'm sure you've heard people talk about right heart failure versus left heart failure. And on the tests, students always get them backwards. Okay? So rather than just memorizing symptoms of right heart failure and left heart failure and then getting them backwards on the test, I want you to think it through logically according to the way the blood flows through the heart. Because if you think it through logically, it should only make sense one way. Okay, so let's walk our way through the circulation of the heart. Okay, so blood's going to return to the heart from the venous system, right? And when the blood returns to the heart, does it return to the right side of the heart or the left side of the heart? It comes back to the right side of the heart. And where does the right side of the heart pump the blood to? It pumps the blood to the lungs to get oxygenated, right? And from the lungs, then where does the blood go? From the lungs, the blood goes to the left side of the heart, and the left side of the heart pumps the blood to the arterial system. Okay, so if you know this, then you should be able to use this to figure out, forward effects and backward effects of both right and left heart failure. So remember this. If you need to draw this out on your scratch paper during the test, do it to make sure that you don't get the symptoms of right heart and left heart failure mixed up. Okay? All right, let's start with right heart failure. Where is your right heart supposed to be pumping blood to? To the lungs, right? So if the right heart fails, the forward effects are going to be that it does not pump blood to the lungs, so it does not pick up oxygen. So now you're going to have somebody who's probably hypoxic, short of breath, and they're going to have the symptoms of hypoxia. They're going to have tachycardia, they're going to be anxious because the blood isn't being pumped forward to the lungs to get oxygenated. What about backward effects of right heart failure? If the right heart is not pumping the blood forward, that must mean the blood is backing up, right? Where is the blood going to back up? Okay, well, since the venous system is supposed to send blood to the right heart, if the right heart is having blood back up, it's going to back up into the venous system, right? And one of the first places you're going to see that effect of it is in your jugular veins. So you remember when we talked about the heart valves, we noticed that there are no valves at the entrance to the atria, right? So there's really nothing to keep the blood from backing right out of that right atria into the venous system. And so one of the first things you're going to notice is jugular vein distension. You've probably already talked about jugular vein distension in health assessment, but you remember that those veins are usually flat, right? But you can see here how distended they are. They're sticking out, and that tells you there's excess blood in there. As the blood continues to back up in the venous system, now the veins have way more blood in them than they're used to. And the veins get kind of distended, but the veins can only stretch so big. And if we continue to try and put more blood in them, eventually some of that fluid's going to get pushed out of the veins and go into the tissues. And so now we're going to start seeing edema. Usually that edema is going to show up in the legs, the ankles, the feet, and so we call it peripheral edema. But sometimes you might hear it referred to as dependent edema. Do you know what we mean when we talk about the dependent areas of the body? We're talking about the areas of the body that are below the level of the heart. And of course, the areas that are below the level of the heart are going to depend on what position your body is in, right? If you're upright, like standing or sitting, your legs are the dependent areas. But if you're in bed, you're lying flat on your back, the dependent areas are going to be like your sacrum, right? That's the area that's going to be below the level of the heart. So when you start seeing fluid getting pushed out of the veins into the tissues and edema starting to develop, where you're going to find that edema is going to depend on what position the patient's in. Does that make sense? As the blood continues to back up in the venous system, eventually you're going to see congestion or the accumulation of fluid in the abdominal organs, because you know that the abdominal organs are sending blood back to the heart, right? But if the blood is backing out of the heart, eventually it's going to back up to these abdominal organs, and these organs are going to start getting enlarged. So hepatomegaly is an enlarged liver, splenomegaly is an enlarged spleen, and we're going to see some problems with the liver and the spleen because of that engorgement. With the liver, we're probably going to have some right upper quadrant pain because, your liver's there in the right upper quadrant of your abdomen. With the spleen, we've already talked about some problems that can be caused by an enlarged spleen in it, getting too carried away, removing blood cells, and so forth. And you might eventually see the GI tract become engorged and congested as well. And if your GI tract is all engorged, you're not going to absorb or digest food and fluids very well, people are going to be very uncomfortable, they're going to lose their appetite, that kind of thing. So you remember that when the veins have too much blood in them, some of that fluid is going to get pushed out of the veins into the tissues, right? And so if some of that fluid that gets pushed out of the veins ends up in the peritoneal space, then you're going to have somebody with ascites. So here's what ascites looks like in real life, but this case is probably a little bit too severe for somebody in right heart failure. You will probably see some ascites, but not quite this bad. But I just wanted you to see what it looks like in real life. The last symptom of right heart failure I want to mention is weight gain. Because you know when fluid gets pushed out of the vessels into the surrounding tissues, it's much harder to get rid of it, right? And so this person has all this edema, they're going to retain fluid. So, you know, fluid is heavy. And so this person is going to gain weight. And just as a rule of thumb, every pound the person gains represents about 500 milliliters of fluid. So if your patient gains 2 pounds overnight, how much fluid did they retain? Probably about 1,000 milliliters, right? Now, contrary to popular belief, it's really hard to gain 2 pounds of fat overnight. So if your patient gains 2 pounds overnight, it's fluid, okay? Now, what if it's your left ventricle that fails instead of your right? Now let's see what's going to happen. Okay, so where is your left heart supposed to pump blood to? It's supposed to pump blood to the arterial system. So if it's not doing that, now your body tissues are not getting enough oxygenated blood. So patients are going to complain of things like being really tired and fatigued, having poor activity tolerance because, you know, if their muscles aren't getting enough oxygen, they can't make ATP, and so the patient's going to be very tired and weak. Now, if your body tissues aren't getting enough oxygen, it interprets this as a crisis, right? And it's going to activate the sympathetic fight or flight stimulation. And so you're going to have increase in heart rate, increase in force of contraction to try and bring the cardiac output back up. You know, so your patients are going to have tachycardia, they may have that sweaty, pale, cool, clammy skin, and that kind of thing from sympathetic stimulation. If the heart failure is severe and the cardiac output drops a ton, the blood pressure may drop and, you know, we may not be able to perfuse our body organs. The patient may actually go into shock. If that happens, we call it cardiogenic shock because that indicates that the cause of the shock originated with the heart. And of course, you know, when the person goes into shock, they aren't perfusing their body organs adequately. They might go into multi-organ failure. This could actually cause people to die. Now, what about the backward effects of left heart failure? If the left heart is failing to pump the blood forward to the arterial system, where is it going to back up? It's going to back right up into the lungs. You remember there are no valves at the entrance to the left atria either, so there's nothing from keeping the blood from backing right out of the left atria into the lungs. And when the vessels in the lungs have way more blood than they're supposed to, you know, the vessels in the lungs can only stretch so big, and after that point, some of the fluid is going to get pushed out of the vessels in the lungs and go into the lung tissue. And then you're going to have pulmonary edema. All that fluid that got pushed out of the vessels in the lungs will end up in the alveoli. And, you know, if you have fluid in your alveoli, that's definitely going to impair gas exchange. So now you're going to have somebody with hypoxia. So you expect to see all the symptoms of hypoxia, like shortness of breath, tachycardia, anxiety, and so forth. But remember, this person also has fluid in their lungs. And when you do an assessment, you're actually going to be able to tell that there's fluid in the lungs. Because they're going to have like a moist cough. When they cough, you're going to hear the fluid kind of rattling around in there. And they're going to have what we call crackles, which is the sound that you hear through your stethoscope when air is moving through fluid. Now, I don't think you've covered crackles yet in health assessment, so let's talk a little bit about it. So we just said that crackles is the sound that air makes when it's moving through fluid, and we often divide it into fine versus coarse crackles. The fine crackles being what you hear when air is moving through fluid in smaller airways, whereas coarse crackles involves larger airways. As far as what they sound like, some people say fine crackle sounds like what you hear when you pour milk in your Rice Krispies. Other people say, if you get some of your hair, grab it between your thumb and your forefinger and then move it in front of your ear and rub your thumb and forefinger together, that noise is kind of like fine crackles. Coarse crackle sounds a little bit more like that slurping noise that you hear when you're drinking out of a straw and you get to the fluid at the bottom of the cup. I'm sure you all know what that sounds like. That's more like coarse crackles. Another thing you might see in left heart failure is orthopnea, or some people call it paroxysmal nocturnal dyspnea. Now, orthopnea just means difficulty breathing when you lie down. Okay, paroxysmal nocturnal dyspnea means basically the same thing, because dyspnea means shortness of breath or difficulty breathing. Paroxysmal just refers to episodes or attacks, and nocturnal means at night, right? So we're having attacks of difficulty breathing at night, which is when you're most likely to be lying down, right? So the question becomes, why do people with left heart failure have more trouble breathing when they're lying down? Okay, so what happens is when you're in the upright position, just because of gravity, there's more blood in your legs than usual, right? Because, blood, once it gets to your legs and when it wants to return to the heart, it has to go against gravity. So just because of gravity, there is always more blood in your legs when you're in the upright position. When you lie down, you lose that effect of gravity, right? So there's no longer anything keeping all that extra blood in your legs. That blood is going to start returning to the heart. And once it returns to the heart, it's going to get to the lungs and get backed up there, right? Because it's not going forward since the left heart has failed. So bottom line, when people with left heart failure lie down, the pulmonary edema gets worse because they have extra blood returning towards the heart and it all gets stuck in the lungs. Does that make sense? So if pulmonary edema is severe and people have a whole bunch of fluid in their alveoli, basically they're going to just drown in all of that fluid that's in their lungs. So for comparing left heart failure to right heart failure, remember that right heart failure causes peripheral edema, left heart failure causes pulmonary edema, right? Because depending on which ventricle failed, the blood is going to be backing up in different areas of the body, right? Now notice both right and left heart failure cause hypoxia, right? Right side failure causes hypoxia because the blood isn't getting pumped to the lungs to pick up oxygen. Left heart failure causes hypoxia because the blood is backing up in the lungs and we have pulmonary edema, right? So both right and left heart failure cause hypoxia, but only left heart failure causes pulmonary edema. Got it? Now we've been talking about right heart failure and left heart failure, but keep in mind that once one ventricle fails, eventually the other one's going to fail too. Okay, here's why. Let's say your right ventricle fails first. If the right ventricle is not pumping blood forward, does the left ventricle get any blood to pump? No, right? And if the left ventricle doesn't have any blood to pump, you're not going to have cardiac output and you're going to be in left heart failure, right? What if your left ventricle fails first? Well, if your left ventricle fails, the blood's backing up in the lungs, right? And if you have a lot more blood in your lungs than normal, what does that do to the blood pressure in the lungs? The blood pressure is going to go up. If the blood pressure in the lungs goes up, what does that do to the workload of the right heart? Yeah, the right ventricle is trying to pump blood into the lungs against a whole bunch of high pressure. The right heart gets overworked, it gets overwhelmed, eventually it's going to fail. See, so it doesn't really matter which side fails first, eventually they'll both fail. But our goal is to catch and treat early, so hopefully we can prevent the other side from failing as well. Does that make sense? All right, interventions for heart failure. Well, first of all, we're going to try and figure out why the heart failed in the first place, and if we can correct that, we will. Okay, so if the cause of the heart failure was really high blood pressure, we'll try and fix that. Or if the patient was really fluid overloaded and that overworked the heart, we'll try and fix that. Okay, not all causes of heart failure are fixable, though. Like if somebody has a heart attack and part of the heart wall died, we can't fix that. Right? So now we're going to try and give medications that can hopefully improve the heart function. So we might give some drugs that increase myocardial contractility, that increase the force of contraction so cardiac output can improve. This would involve some kind of positive inotropic agent. Maybe digoxin is an example of a drug that can increase the force of contraction of the heart. We might give drugs to get rid of some of that edema fluid that's being retained because, you know, if you have fluid overload, that increases the workload of the heart. So maybe we'll give diuretics, or maybe we'll just restrict sodium. We might give drugs to try and decrease the workload of the heart. Like maybe we'll give a drug to get rid of some of that extra blood volume, or we might give a drug to slow the heart rate, or we might give a drug to lower the blood pressure so that the heart doesn't have to pump so hard against all that pressure. Of course, we have to monitor these drugs carefully to make sure that it doesn't do the opposite and make the cardiac output worse. But in moderate amounts and carefully monitored, these kinds of drugs can be helpful. And then we might give drugs that can block the activity of the sympathetic nervous system or the renin-angiotensin-aldosterone system, because you remember we did say these are compensatory mechanisms that can work in the short term, but in the long run may have some counterproductive effects. So again, we'll be monitoring the effects of those kinds of drugs carefully. If we have somebody who gets so bad that they're in what we call end-stage cardiac failure, maybe the only thing we could do for this person is suggest a heart transplant. But, you know, donor availability for heart transplants is a problem, and so that's not an option for as many of the people as we have who have heart failure. Let's talk now about the second major component of the circulatory system, and that's the blood vessels. So in this picture, you can see the structure of the three different kinds of blood vessels we have, which are the arteries, the capillaries, and the veins. Okay, you'll notice that the structure of the arteries and the veins are pretty similar. They both have 3 layers to their vessel wall. The outer layer is made of tough, fibrous connective tissue, and the job of that layer is to support and protect the vessel. The middle layer is smooth muscle, and that's the layer that will constrict or relax to adjust the blood flow to meet the needs of the body tissues. The very inside layer is the endothelial layer that, remember we said, is smooth and slippery and prevents platelets from sticking to it, and also makes some useful substances that keep you vasodilated and keep platelets from sticking to it so the blood can continue to move freely through those vessels. Now notice that the vessel walls of the capillary are different from the arteries and the veins. The capillary walls are only one layer thick. Basically, the capillary walls are just that endothelial layer that's on the insides of the other vessels. And that's a good thing because the thin walls of the capillary facilitate the exchange of gases and nutrients and wastes that takes place in the capillaries. Okay, so now that we know what the capillaries do, what is the job of the arteries as opposed to the job of the veins? Okay, so which one carries blood to the tissues? Which one brings blood back to the heart? Okay, the arteries carry blood to the tissues. The veins bring blood back to the heart. Let's talk about artery problems first. Okay, since we said the job of the arteries is to carry blood to the tissues, if there's a problem with the arteries, blood won't get to the tissues, right? Now we can divide arterial diseases into two groups, chronic versus acute. You remember chronic issues usually take a lot longer to develop. The symptoms are not so bad to start with, but they get worse over time. And once you have it, you pretty much have it forever. Acute problems come on much more quickly and suddenly. The symptoms are usually more severe to start with, but you can get rid of acute problems. You don't live with them forever. The acute problems are either going to kill you or they'll eventually go away. Okay, so we have both chronic and acute problems with the arteries. Chronic problems are usually due more to things like atherosclerosis because atherosclerotic plaques are things that take a while to develop, right? Acute problems are more often related to something like a clot because, you know, blood clots can develop very quickly. Let's talk about symptoms of chronic arterial impairment first. Now let's say I have a whole bunch of atherosclerosis in an artery leading to my foot. Okay, so if I have all this blockage in the artery to my foot, does that mean I'm going to have trouble getting blood to my feet? Or can I get blood to my feet and I can't get it back to the heart? I'm going to have trouble getting blood to my feet, right? So if I have trouble getting blood to my feet, do you think my feet are going to be pale or red? Pale. Are they going to be warm or cool? Cool. Are my pulses going to be strong or weak? Weak. What about capillary refill? Yeah, it's going to be slow. There might also be some paresthesias, which, as you remember, means that there's numbness and tingling and other kinds of weird sensations. If you think about it, that makes sense, right? Because when your foot goes to sleep, what do you say? You say, oh, my circulation got cut off, right? So that implies the arterial blood's not getting to your foot. That's what causes that pins and needles, numbness and tingling feeling that you get when your foot goes to sleep. And there's often pain as well, because you remember when tissue isn't getting enough oxygenated blood, usually the result is pain, right? In chronic arterial disease, we call it intermittent claudication. People will off and on have pain in their leg muscles, usually when they're walking. Because if you think about it, when they're walking, that's when their muscles are being active. They need more oxygenated blood. And if the arteries are all clogged up, we can't supply that extra blood. So the pain's going to occur when the person has been using their leg muscles. Sometimes if you look at somebody's chart, the doctor will have written, oh, this patient has 1 block claudication, meaning they can walk 1 block before their leg muscles start to hurt. You might actually see somebody also complain of pain when their legs are elevated because, you know, when your legs are elevated, now your arteries have to get blood to your foot against gravity, right? So it's going to be harder. Less blood is going to get to your foot. So we frequently see people with arterial problems complain of more pain when their legs are elevated. You will frequently see people with really thick, brittle toenails as well, because since the arteries are clogged, the nails aren't getting as much oxygen and nutrients as they need in order to be healthy. So the toenails end up looking really kind of gnarly. If you've ever looked at the toenails of your patients, especially the older ones that often have some arterial problems, you'll see these really thick, brittle toenails. And then we often see ulcerations because there's not enough oxygen getting to the tissues. Some of the tissue is going to die. Okay, now the arterial ulcers have a very distinct look. Sometimes people call them a punched out kind of look, which almost looks like, somebody took some kind of hole puncher and punched out some of the tissue there, because you see the edges of that ulcer are very distinct. That just kind of really sharply outlines which area of the tissue is not getting arterial blood flow. And the arterial ulcers also tend to look very pale and dry because there's not blood getting in there. So it's going to not be red, and it's not going to have a lot of extra fluid around. So the ulcers tend to look really dry as well. Sometimes the arterial ulcers will get this hard black eschar on top of it. And it kind of looks like a scab, but it's not. It's actually dead tissue. Okay, and actually, in order for that ulcer to heal, we would have to debride or cut away that dead tissue in order to have normal healing. Worst case scenario, if the lack of blood flow to the foot is really bad, we might see over time something like a toe just dying, right? So that second toe on that foot is just dead. And you know that it occurred over a fairly long period of time because notice how dry it is. If that toe had, necrosed and died over a short period of time, it would still be kind of wet and soggy. So that toe is basically just dead. In fact, if you were to grab it and just kind of yank on it, it would probably break off in your hand because it's dead, which I know sounds kind of gross, but I have a colleague who was working in the ER one day, and she said a lady and her husband came in, and the lady had her husband's toe in a Ziploc bag and said, "Can you reattach this?" And his toe had looked just like this, and it just was all dead, and it had just broken off because it had gotten dried out. And of course, they could not reattach that because that toe was just dead. So those are the symptoms that you would see in chronic arterial disease. The symptoms in acute arterial disease are actually very similar, only they come on much more quickly and they're more severe from the outset. So you notice instead of saying the foot would be cool, we're saying it's cold. Instead of the pulses being weak, now we're saying they're absent. So sometimes people use the acronym, the 7 Ps, to remember the symptoms, and they are very similar to the symptoms that we just talked about for chronic arterial disease, with the addition of that last P at the bottom, which is pistol shot. Okay, that's just in there to remind people that acute arterial occlusions usually happen quickly. Like, when you shoot a gun, the bullet travels very quickly. Okay, so that's just to remind you that the acute problems come on very quickly. So here's a picture of someone with an acute arterial occlusion, and you can see that really the circulation to this leg is so poor. The leg is pretty much dying right in front of your eyes. Look at how black the toes are already on that foot. But it's not all dried out yet, right? So it didn't happen over a long period of time. This happened quickly. And here's another example of something that probably happened very quickly because the bottom of that foot is all black, but it's not dried out yet. So, okay, let's say a few words about the capillaries. we did say that the capillaries were where the actual transfer of gases, nutrients, and waste takes place between the blood and the cells. Now, we also said that the capillary walls were very thin. They're really only that single endothelial layer thick. And that is to facilitate the transfer of all of those substances. The capillaries are also very tiny. I read somewhere that the capillaries are just wide enough to allow one red blood cell at a time to go through. So they are very tiny, but because there's so many of them, and the walls are very thin, and they're located so close to the cells, that is sufficient to make sure that the transfer of gases, nutrients, and waste takes place. Because there are so many capillaries, there is a large surface area. And so, again, we can make sure that every cell gets the transfer that they need. So here's a picture where you can see all the capillaries in the body. I got this picture from the Body Worlds exhibit. I don't know if you've seen it, but it's really cool. They took a body and they treated it somehow to get rid of the tissue around it, but to leave the blood vessels there. So you can see how many capillaries there actually are and why there is sufficient surface area to ensure adequate transfer of gases, nutrients, and wastes. I read somewhere that every person has about 10 billion capillaries in their body. And somebody actually calculated out the surface area that's available in all those 10 billion capillaries. Now, if I told you that there's enough surface area in all the capillaries in your body to be equivalent to a football field, would you be impressed? I mean, think about how much bigger a football field is than your body, right? That sounds pretty impressive, but in reality, your capillaries have enough surface area to be equivalent to 100 football fields. Okay, so now you can understand why there's enough surface area to make sure that every cell in the body has enough transfer of gases, nutrients, and wastes. Now, if there's a problem with your capillary, that's going to interfere with that transfer of oxygen, nutrients, and waste. So the symptoms that you're going to see are going to depend on which capillaries are affected and what tissue those capillaries supply blood to. Let's move on to the veins. Now, we said earlier that the veins' job is to bring blood back to the heart from the tissues, right? And it also serves as storage for blood. You remember the walls of your veins are thinner and stretchier than the artery walls, and so they can serve as a good reservoir to store blood. As a matter of fact, at any one point in time, about 2/3 of your blood volume is in your veins. So your blood is not equally split between your arteries and veins. More of your blood is actually in your veins than in your arteries. Now, you remember that your veins are a lower pressure system than the arteries, right? Because they're stretchier, and so they can expand more. The pressure inside is not as great. So let me ask you this. If the veins are a low pressure system, then what is it that keeps the blood moving back towards the heart? Because if you think about it, a lot of the veins have to return blood back to the heart against gravity, right? So if they're a low pressure system, what is it that keeps the blood moving back towards the heart? So we have two things to keep the blood moving in the right direction. We have valves in our veins, and we have what we call skeletal muscle pumps. Let's talk about the valves in the vein first. So you see those little leaflet-looking things in the picture on the left, right? Notice how they're positioned so that the blood can go through the valves to return back to the heart, but they can't go the opposite direction because the way the valves are positioned in the vein, it prevents the blood from going backwards. Okay, so that's the first thing that we have. The second thing we said was skeletal muscle pumps. And we call it that because when the skeletal muscles contract and relax, that helps pump the blood back towards the heart. Okay, so let's think about this. When the skeletal muscle contracts, it kind of gets shorter and fatter, right? And when the muscle relaxes, it gets longer and skinnier. So if you have someone who's walking, then their leg muscles are doing this contract, relax thing, right? And so what's happening when this person walks is their skeletal muscles in their legs are getting fat and skinny and fat and skinny. And from the picture, you can see that when the skeletal muscles contract and they get fat, they're kind of squishing the vein in between the muscles. And that's causing the blood to shoot back towards the heart. Now, technically, you might wonder why the blood doesn't shoot in the opposite direction. But remember, there are the valves there to prevent the blood from going backwards. So between the valves and the pumping action of the skeletal muscles, that's what kind of milks the blood back through the veins and towards the heart. Now, if we have a problem with either our valves or our skeletal muscle pumps, now we might have some problems getting the blood to go back to the heart. In the picture on the left, you can see somebody with unhealthy or incompetent valves in their veins. Incompetent meaning it can't do its job, right? So you see how in that vein, the vein got kind of stretched out, and so the valves get pulled apart, and they can no longer prevent the blood from going backwards. The most common thing that prevents your skeletal muscle pumps from doing their job is immobility. Are you familiar with that term yet? Immobility is what we call it when somebody is stuck in bed and they can't move around. You know, your body was meant to move, and when you take that body and you stick it in a bed and don't let it move around, a lot of things start to go wrong. We call them the complications of immobility, and there are a bunch of them. And here's the thing. It's the nurse's responsibility to prevent those complications of immobility, because we know what they are and we know the best ways to prevent it. So if some of those complications of immobility do develop in somebody who's in the hospital, especially if they didn't have it when they came in, then a lot of times insurance companies will refuse to pay for the cost of treating that complication because they say, well, you know what? Your nurses were supposed to prevent that from happening, and so it's your fault that they have it. We're not going to pay for it. So it's a really important thing for us to learn about these complications of immobility and how to prevent them. So how does immobility affect your skeletal muscle pumps? Well, remember we said your skeletal muscles do that pumping action when they're contracting and relaxing. If you've got a patient who's lying in bed, are their leg muscles contracting and relaxing? No, right? So we lose that pumping action, that compression on the vein that's going to shoot the blood back towards the heart. And so we end up with what we call venous stasis. Do you know what stasis means? Stasis means stagnant. It's not moving. So if your blood is not moving through the veins back towards the heart, but it's just pooling in the veins, that's what we call venous stasis. And I put this slide in here because I used to talk about the blood pooling in the veins. And one quarter I got some really weird answers on a short answer question for a test. Because people were saying, oh, something about the blood pulling on the veins. And I'm like, blood pulling on the vein? How does it do that? And then I realized that when I said the blood pools in the veins, they thought I meant the blood was pulling on the vein. Okay, so I'm spelling it out so that you don't get that mistaken impression. When I talk about blood pooling in the veins, I mean the blood is collecting in the veins. It's stagnating in the veins, so we have venous stasis. Now, we did say that the job of the veins is to bring blood back to the heart. So if there's venous impairment, we expect that the blood can't get back to the heart, but is instead going to pool in the lower extremities. We do have chronic and acute forms of venous impairment. Remember, the chronic forms take longer to develop, more slowly. They start out mild and become more severe. Once you have them, you're pretty much stuck with them for the rest of your life. Whereas the acute problems come on much more suddenly and more quickly. They're usually more severe from the onset, but they don't last forever. You can usually get rid of them. All right, so when you have chronic venous problems, they're usually caused by things that develop slowly, like immobility. Most people don't become immobile overnight. Valves don't usually become incompetent overnight. Whereas acute venous problems are very often due to clots. And you remember, clots can form very quickly. So let's talk about the symptoms of chronic venous impairment first. Okay, so we said the job of the veins is to bring blood back to the heart, right? So if the veins are impaired, we can get blood to our feet, but we can't get the blood back to the heart. That means there's a whole bunch of blood collected in your foot, right? So would you expect your foot to be warm or cool? Warm, right? Because there's a whole bunch of blood there. Would you expect the skin to be pale or pink? Pink, right? Because there's a whole bunch of blood there. Would you expect your pulses to be strong or weak? Probably strong, because remember, we can get the blood there, we just can't get it back to the heart. What about capillary refill? Would you expect that to be fast or slow? Probably fast, right? Would you expect there to be swelling? Yes, right? Because there's so much more blood in your foot than there usually is. And remember, your veins can only stretch so much. And if there's more blood coming in, then some of that fluid is going to get pushed out of the vein into the tissues, and you're going to have swelling or edema. So here's a picture of somebody with chronic venous insufficiency, and you notice that there is swelling present, and the skin is pinker than usual, almost red, okay? And you notice that both legs are affected. Usually when somebody has chronic venous insufficiency, they do have problems with both legs. Now, when you elevate the legs of somebody with chronic venous insufficiency, would you expect the symptoms to get better or worse? Usually they're going to get better, right? Because when you elevate the legs, now you're making use of gravity to help move some of that blood back towards the heart. So remember, in chronic arterial problems, they get worse when the legs are elevated. In chronic venous, they get better when the legs are elevated. Chronic venous insufficiency can also cause ulcers. We call them venous stasis ulcers. And, normally you would think that ulcers would occur with arterial problems, right? Because if the tissue isn't getting enough oxygenated blood, it's going to start to die. But, venous impairment can cause ulcers too, because if you think about it, the circulation is like a circle, right? The blood goes from the arteries to the veins, back to the arteries, back to the veins. So can you see how if you prevent the veins from bringing blood back to the heart, eventually that's going to make the arterial blood flow sluggish too, right? So when venous impairment gets more severe, that's when you're going to notice some of that blood backing back out of the veins to affect the arterial blood flow as well. And when the arterial blood flow starts to become sluggish, then the tissue becomes very vulnerable to damage, and we might start seeing some venous stasis ulcers occurring. Now, you notice that you can really tell the difference between a venous stasis ulcer and an arterial ulcer because they look totally different, right? Remember, the arterial ulcers were dry and pale. The venous stasis ulcers are red and wet looking, right? They're red because there's a whole bunch of blood in that foot. and they're wet because of all that edema fluid that's in the tissues. So it's actually pretty easy to tell the difference between an arterial and a venous ulcer. Here's another picture of a venous stasis ulcer. Again, notice how red and wet looking it is. A lot of people say that venous stasis ulcers have like a beefy or like a raw hamburger look. And here's a shot of somebody who actually has both arterial and venous issues, right? You know they have venous issues because look at the swelling in that foot. But you know there's also arterial issues because of the discoloration, and look at the toenails. Okay, those are some pretty gnarly toenails there. The acute form of venous impairment usually takes the form of a DVT, which stands for deep vein thrombosis. Thrombosis means clot, right? So we've got a clot in the leg vein. And actually that makes sense, right? Because when you have venous stasis, that means the blood is stagnating in the veins, right? It's not moving very fast. And whenever you have blood that's stagnating, that's just laying around, what does it want to do? It wants to clot, right? So now we have a clot there, and the clot in the vein kind of irritates the vein, and the vein becomes inflamed. So sometimes we refer to DVT as thrombophlebitis instead. The thrombo meaning clot, the phleb referring to vein, and then the itis, inflammation, right? So we have inflammation in a vein due to a clot. As you might imagine, because there's inflammation present, we're going to see those signs of inflammation, right? There's redness, heat, pain, and swelling. And notice that usually when there's a DVT, it really affects only one leg, right? There could be the possibility that a clot would form in both legs at the exact same time, but that's not that likely. So most of the time, if you see one leg more swollen, more red than the other leg, there's a good chance that there is a DVT there. Now, if you look at the patient's other leg, there probably is some chronic venous insufficiency there as well. There does look like some swelling on the ankle, but notice that the swelling isn't as big. The leg with the DVT is redder, because now there's inflammation. It's not just a lot of blood there, but there's inflammation present as well. And it's probably going to be hotter. Right? We said chronic venous insufficiency would probably cause warm skin, but the DVT is going to cause hot skin because of the inflammation that's present. Does that make sense? I just want to mention Virchow's triad before I finish. Virchow's triad is a list of 3 things that predispose to DVT. Venous stasis is the one that we've been focusing on, but also there's hypercoagulability, which just refers to anytime the blood is more likely to clot. That could be caused by something as simple as getting dehydrated, so that, the blood is thicker and sludgier and wants to clot more. Or it could be something like there's a blood disorder. Injury to the vessel wall could be, due to somebody banging into your leg and damaging the vein, or it could be maybe I started an IV in that vein and that injured it. Okay, these are things that commonly lead to DVT. The reason I focused on the venous stasis is because that's probably the more common cause, and that is the complication of immobility that you as nurses should be preventing. When you get into, I think, fundamentals in second quarter, you'll probably learn a lot more about how to prevent DVT. So I'll leave it at that for now. Okay, I want to leave you with one last piece of advice, and that is, please compare all those disorders that are easy to get mixed up. Right heart failure versus left heart failure. chronic and acute arterial and venous impairment. You know, if you get chronic and acute mixed up, or if you get arterial and venous mixed up, it's going to be wrong, okay? Make sure you understand the logic behind why each disorder causes the symptoms it does. Don't just memorize lists of symptoms, because when people memorize, you know, it's so easy to just switch the headings on the list that you memorized, and now you're getting everything backwards. So please make sure you review that. If you have questions, please let me know. Otherwise, I'll see you in class. Bye.